Hi, thank you for having me. We're going to be talking to you about the evaluation and post-surgical management of hernias. Second there. So we're going to go over what are hernias, the different types of hernias that we have, what kind of non-operative treatment we can offer patients, if we need imaging, which is the best option, and when do we need it. We're going to talk about the technique to reduce hernias, go over briefly over diastasis recti, that I get a lot of patients referred to me thinking that they have a hernia when they don't. Talk about the pre-op limitations, what are the surgical risks of the surgery itself, when do we need a mesh during the repair, and what are the post-op limitations for that patient. So hernia means a rupture. So how I explain it to patients always is that we have like an internal girdle, the fascia, so they, I don't know, understand, like an abdominal binder inside, that we have a little hole in it, and that's where the intestines or any abdominal content is gonna go through. So I try to explain to them, we repair hernias, we don't remove them. And this is something that we can get from birth, I think most of the time, or they can be acquired like from different surgeries, from mechanical stress, wear and tear. And they all over time, eventually for the most part, end up getting bigger and bigger. Some of the risk factors to develop them or get them to become bigger are coughing, smoking, obesity, constipation, increasing on intra-abdominal pressure. Whatever you have that can fit through that defect is going to go through. It can be intestine, it can be a liver, a spleen, but the most common is small bowel or omentum that go easily through small defects. So hernias can occur pretty much anywhere in your abdomen or anywhere you've had an incision in your abdomen, including your belly button, your inguinal area, which are the most commonly seen. We can also have internal hernias from adhesions from different surgeries or from defects left from previous surgeries where the bowel gets in through that defect or that adhesion and gets like twisted in there or stuck in that defect. And that can lead to a small bowel obstruction. We can get them also at the diaphragm. A lot of those can be congenital by the esophagus. Sometimes they can be also from a previous trauma. And obviously in the abdominal wall, higher from the belly button, epigastric ones, pigilians, and incisional, like we mentioned. So I'm gonna go through a few photos of patients of mine and how they look so we know how to identify it. I often get patients come in that look like this with imaging done that is not necessary. That just by seeing this, you should know this is a hernia. There's nothing else I need to look for. There's some people who always are gonna get some imaging, but for the most part, if anyone looks like this, I don't order anything else. So whenever you have outpouching or like protrusion of your belly button, that's not normal, that's not an Audi, that's a hernia. Even this one, if you see it popping out, it's a hernia. And I like to always see my own CT scans, no matter what the radiologist reported. A lot of times they miss small hernias, so don't mention them. And so here, if you look at your transverse slice of your CT scan of the abdomen, you should be able to follow your muscles and fascia all throughout. And here you can see that we have a gap and we have the hernia sac that you can follow here. So you have small bowel protruding and all this gray area is just probably omentum protruding along with the small bowel. So a lot of times radiologists, when they do report them, in obvious ones like this, they're gonna report the size of the sac. The size doesn't really matter at all for the repair itself. What matters is the size of the gap, which a lot of times they don't mention. The size of the gap is what I'm gonna use to decide what kind of or what size of mesh I'm gonna be needing. So you might have a big sac with a lot of stuff stuck in it and a very tiny hole. Okay. So umbilical hernias should, for the most part, always be repaired. It's a point in the abdomen of high pressure, and they end up getting incarcerated more often than not. If the patient comes to you and they're completely asymptomatic. Mostly they're very, very tiny ones with a little bit of fat incarcerated, so they don't even know they had it. Those you can just let them be and wash it and just educate them and let them know if at some point you start getting pain, you start getting a larger bulge visible, any discomfort, redness, then I think that would be the time to operate on it and not let it get super big. So we have different methods of how we can repair them. We can do either primary repair or minimal invasive repair. So when they're very small, like 1.5 2 centimeters small, we can repair them primarily, just suture the defect without putting a mesh in. So in this case, I just open down through the belly button, remove some of the redundant skin, and then I close the fascia, and on the inside without a mesh, in this case it was tiny, and try to like pull back in the skin so it looks better and it tries to regain the appearance of a normal umbilicus. A lot of other surgeons just go through here and do like a large incision over the belly button, but that one's more visible. This one normally heals really nice and you barely see incision later. This is a patient of mine who he's a personal trainer and an actor, and whenever he would put up pictures on Instagram, even though his hernia was tiny, he was already getting messages on Instagram from unknown surgeons to him about offering to repair his hernia, and he was bothered that it looked like a smiley face. So this one was less than 1 centimeter. It had just a little bit of fat stuck in there, which is what's popping out here. And so I just opened through the middle again and pull back in the umbilicus, and he was happy with his appearance. And so here, no mesh, they all go home the same day. When we have more obese patients, even if we have a small hernia, which in these cases, this is much bigger, his sac and what's protruding is a lot bigger than what his inguinal ring really was. We do recommend more minimally invasive approach because recurrence is much higher in these patients with risk factors. If you do an open repair or one of those open small meshes. So here I did a robotic surgery. These are the 3 incisions you can see here. We come from the lateral side. I close from the inside the defect in the fascia. And then I pull back in again the umbilical skin, and then put a very big mesh around here. And he actually had a car accident only, I think it was a few weeks after his surgery. He got into a very bad car accident and his hernia was fine. It didn't reoccur so far, so we're good there. Pregnancy, I see a lot of pregnant women whenever you have the same, an Audi, it's a hernia. They might be very tiny defects, so when they deliver, they might be pulled back in and they might be fine and not have symptoms. But a lot of pregnant women end up getting surgery after pregnancy for hernias. You want to try to avoid operating on these hernias during pregnancy, obviously, and ideally wait at least 6 to 8 weeks after they deliver to do the repair, so the tissues are like gone back to their place. If you do have to repair it during pregnancy, probably they will want to avoid putting a mesh because that belly is gonna keep getting bigger and that's gonna reoccur anyway, has a very high chance. So our second most common hernia is gonna be inguinal hernias. It's just a weak point in the inguinal canal. There's really no proven link between lifting weight or doing an exercise, carrying heavy loads, and getting inguinal hernia. So a lot of times you get workers' comp patients saying, oh, I lifted weight and suddenly I felt a pop. Yeah, you might have felt a pop then because the pressure pushed out your small bowel, but your defect was there already. So on contrary to the, different from the umbilical hernias, inguinal hernias, we can do watchful waiting if the patient doesn't have any significant symptoms. If they don't have discomfort, they don't mind, it's okay. You can just watch it, and watch it means just come back to see me if you have any discomfort. You don't have to be doing imaging. It doesn't matter if it grows or not. Studies have shown that surgery, earlier surgery when first symptoms arrive, such as pain, do not have any disadvantage if we wait for the symptoms to arrive. So patients do as well. And they don't get more complications. So as soon as they have any discomfort, if they don't like it, if whatever bothers them, you can already have an indication. That would be an indication for surgery. And if they are always the ones who don't want surgery or want to wait before they decide to go through with it, I always advise or teach them that if they ever get pain or start getting the bulge becomes tense or larger than usual, I teach them to like lay down, flex their knees, put an ice pack for 5-10 minutes, maybe some Tylenol, and then start like pushing it in that we're gonna go through, and that can avoid emergency surgery. If this keeps getting worse, if they get pain, fever, nausea, they might have small bowel getting obstructed in there, then those are signs of incarceration or strangulation possibly, and you want to go to ER and get an emergency repair. So we have different ways of we can also do open or minimally invasive surgery here. When we do open incisions, open hernia repairs, we do a long incision on the groin over a defect, and we suture the defect, and we put a mesh or a plug with patch in that area, trying to plug the inguinal canal defect that we get. If you get a direct hernia, we know it's medial to your epigastric vessels, so it goes straight through the superficial inguinal ring. If we have an indirect hernia, then we know it goes through your deep inguinal ring, which is the defect, and then it keeps pushing back in until it goes it could go all the way down to the scrotum. So you always should repair inguinal hernias with a mesh, except in the case of contamination, where infection of the mesh is high, and you want to avoid that because that can be very bad for everyone. When we do minimally invasive, on the contrary, we open, like I showed you before on the side, but like above the belly button, we do 3 incisions as well. And we localize the defect. We open a flap, we bring down the peritoneum, bring down back into the abdomen, anything that might be obstructing that defect or protruding, and we put a big patch on the inside. So we don't have to open on the outside. It's a much larger patch. Evidence, if you pay attention to evidence, there's really no difference in recurrence still that they've seen between minimally invasive inguinal hernia repairs and open. In my experience, I think it's a better surgery, but there's no evidence that it's better than the other, aside from recovery at first. It tends to be a lot better, and they don't have tension in that area. They're still pretty painful surgeries, but I don't know, maybe I'm biased, but I haven't done an open one in many years. Let's see. So this is just a little bit more anatomy. When they say you have an inguinal scrotal hernia, they just are so big that they're sliding easily into the scrotum. Inguinal hernias, if you see a bulge like this, the same. It's a hernia. I don't need imaging. Unless it's an obese patient and I'm unable to really palpate, or I'm not sure of if it looks weird, or if it's not a usual area, or sometimes when the patient has such a tiny one that I don't feel anything at all, but they keep complaining of pain, then you can do imaging. But if they're like this, so obvious, and probably you can reduce these ones, you don't need anything else, just surgery. So this is how we see them from the inside when I'm doing robotic surgery. This is the robotic setup here. I'm in the console already. And so here you have this is a right inguinal hernia. So here you have your bladder, your medial umbilical ligament. Here, if you see his depression, he's already probably starting to form a direct hernia, but it's not obvious yet. Here you have your inferior epigastric vessels. And then this hole here, that's your indirect defect. So that's what we're going through. So I just do an incision here in the peritoneum. I bring it down, peel it off completely, and I put a big patch that covers like this area. And here, sorry, this patient in particular had an appendix stuck in the, she had appendix, was a female. She had appendicitis and the appendix was stuck in the hernia. So I get asked a lot about hernia belts sometimes during consults from either elderly patients or from some primary physicians having recommended them sometimes. For some patients, it can cause relief, but in general, we don't recommend them. If you have bowel protruding and you're pinching it with the belt against the abdominal wall or the inguinal area, that can damage your bowel, okay, or even lead to more complications. So usually we don't recommend it unless it's significant the difference they have. And if so, and they insist, I teach them to reduce it and make sure their bowel is inside if they're putting it in the right place. But we try not to have them use it at all. So there's nothing you need. Just if you have discomfort and you haven't had surgery, just pop it back in whenever you get discomfort. So abdominal binders, they're just for support. Binders don't keep the hernia from getting bigger. They don't decrease recurrence rates after surgery. I do tell them always, if a lot of people claim that they feel more comfortable and have less pain if they wear an abdominal binder, especially after surgery, especially more obese patients, it takes off maybe some of the weight from the belly, so they feel better. So if they want to use it, they can use it. Surgically, there's no need for it. It's not going to make a difference in recurrence or anything like that. Okay, so imaging for hernias. We can do most of them, ultrasound, CT scan, MRI. Ultrasounds tend to be first line because it's especially in children, and then in adults, you can do it as well. And if you're unsure if they have a very tiny defect, they might be able to see it, but most of the time they need bowel to be able to, or fatty tissue to protrude through there for them to be able to tell it's a hernia. And obviously it's technician dependent. CT scan, I prefer if I ever have any doubt with very tiny ones that I cannot feel anything and they claim they have pain, or in obese patients where I cannot feel anything maybe either. Then I might order a CT scan without contrast. I only want to see the abdominal wall. I don't really need to see the small bowel or the colon. So no contrast is necessary, in my opinion, or in general. And here I can look at the images and see the defect myself and decide what kind of mesh I need, depending on the size. I can measure it there. And then MRIs, you can always do, it's going to show you the hernia as well. They're a lot more difficult to read. So at least me personally, I don't know as good as on a CT scan what I'm looking at. But if you suspect that patient might not have an actual defect, it might be more of they pull a muscle, or more like a sports hernia. There's just an injury, it's not a real hernia. Then an MRI would be a diagnosis tool. But in general, unless it's a sports hernia that I'm suspecting, I never order MRIs. So when we look at images on the cross-sectional and the transverse images, the same as before, we're gonna follow the fascia. Here you can see this is the bladder, hips, rectum. So here you can see that the pouching, you can follow the hernia sac, and there's no fascia here anymore, okay? Here you can see hernia sac on the left. We're in a lower image there. And then here you can see a small one already, the ligament here and the hernia sac already protruding, okay? And here you can see it's all gray, so it's only fat protruding. And then here you see bowel coming out, which doesn't matter, it doesn't make a lot of a difference what comes out. The only difference is if you get fatty tissue incarcerated or strangulated, you're gonna get a lot of pain, but it's not gonna be detrimental to your health. They're not gonna get, bowel's not gonna die. If it's bowel, that's another story. You have to move along with that one. Okay, so in general, to go over them, you have epigastric hernias whenever it's a hernia above the belly button. When it's a few centimeters around the belly button or over it, that's an umbilical hernia. Direct hernias, they tend to be more like towards the pubic bone, really. And then inguinal hernias tend to be a little bit higher. Femoral hernias tend to be most commonly, obviously, it's elderly women. And they tend to come with them incarcerated, and you're gonna see more of below the groin, more towards the thigh, you're gonna feel a lump. And usually they're incarcerated or strangulated because it's a very small defect. So you're gonna feel a tense round shape there, or like a tense protrusion. So in general, even when they're small, we wanna know if they're incarcerated or strangulated, so we can avoid this. When a hernia is incarcerated, it's that you have some tissue stuck in your defect, in your sac. If this incarceration is acute, they're gonna tell you, they're gonna come with pain. They're gonna tell you, no, like I have a bulge that comes in and out, and suddenly today it popped out when I sneezed, and I was not able to like push it back in. When they have chronic incarceration, though, they might tell you, oh, I always have a small lump that doesn't change, doesn't bother me, and suddenly I sneezed today, and now the bulge became bigger, and now my skin is red, I have a lot of pain, you touch it, it's really tense. So that's an acute over chronic incarceration, and that's where you fear the incarceration might become a strangulation. And if you don't go in there soon enough, then you may have lack of blood supply to your bowel and get necrotic bowel. A lot of times on radiology imaging from ER, they read on the radiology report possible strangulation versus incarceration or whatever. That's a clinical diagnosis. They should never mention that, okay? So obviously, if there's a lot of fast stranding, like it could suggest it, but incarceration is always a clinical diagnosis. So reducible hernias are when we're able to push them back in. They are always, almost always, if they're in ER, they're gonna have some discomfort, but most of them can be pushed back in. And this can be fixed electively at a later time. If you reduce them, no need to rush into the OR. Like I said, acute versus chronic incarceration, and then strangulations. If you suspect it, you wanna go into the OR as soon as possible. Now, these are other patients where more similar to how an incarcerated, a strangulated hernia might look like. When you see redness around your protrusion, then you have to, and it's tense and exquisitely tender, then you have to worry that it might be a strangulation. In general, they say, or they teach almost everyone, that after a certain amount of hours, in the literature you find 4 to 8 hours, you have to suspect strangulation and not to reduce them. In my experience, I always try to reduce them. It might still be just incarcerated and the bowel might be fine. That might be the difference between saving bowel and making it an emergency or not. So obviously, if it's super tense and hard, that might be strangulated. There's no way that's going in. It's a smaller defect compared to all the tissue that came through. So that one I'm gonna leave alone and just go straight to surgery. But here you can see this was a very small defect, and abnormal bowel popped out through the defect and became necrotic. Okay, so this is a strangulated hernia. So you have to cut the bowel, connect it, push it back in. In these instances, some people put meshes that have either biological or some of the new absorbable, partially absorbable meshes. I prefer to try to close, especially in small defects, close the defect primarily and not put a mesh at that time, because the risk of infection is still high, and can be very complicated, give a lot of complications to the patients. So I tell them, we report it primarily, your chances of recurrence are a lot higher, but you're gonna recover from this, make sure bowel is fine or anastomosis is fine, and then at a later time, if you get a recurrence, then we'll do it properly, robotic or laparoscopic. So when we're reducing a hernia, first I always put an ice pack, like I mentioned, try to give Tylenol or Aleve or Toradol if they're in the hospital, so they relax a little bit also. You wanna hold the sac because the hernia is protruding. Maybe here's the neck. If the neck is here, you don't wanna push right at the neck because you have all this stuff coming out. So you wanna take the end part of your sac or protrusion and push back from the end. You're gonna have the patient lay down, like I mentioned. You're gonna have him or her take deep breath, and during exhalation, they relax their abdomen, they relax it. So that's when you wanna push at that time. You can bend up the knees also. And like I said, says here 70% of the hernias can be reduced. Okay, so most people call me, they haven't even touched the patient and they don't try to reduce them at all, or they're always going to have pain. So you cannot, if they have like normal inguinal hernia pain, you're not gonna not touch them because of that. This is gonna relieve their pain so much faster. So if you're not able to reduce it and you suspect an acute incarceration, that's when you're gonna go to the OR, like we talked about. Okay. And in some cases where they had a large one or one that was really difficult to reduce, that patient, I'm gonna educate, I'm gonna explain to them, maybe we're gonna watch overnight if you had an obstruction before coming into the hospital. If they didn't have an obstruction, they can go home for the most part if they feel fine after I've reduced it. But you want to watch over the next 1-3 days for any signs of fever, infection, chills, increasing abdominal pain that might indicate peritonitis or any small bowel perforation, but that's rare. So, skip one. So here's an example of how to reduce the hernia. I always look for the inguinal ring or the umbilical ring if it is up there or wherever the fascial defect is, and you want to like I don't know, like push on it on the bowel that's coming out. So you're like trying to thin that out like they show here, and then from the end of the whatever is protruding, you're gonna like push it back in. Okay. So this is something else that a lot of patients come into the office telling me that they think they have a hernia, or a lot of times already the PCP had told them this is not a hernia, you don't need surgery, but they keep insisting and they're scared it might be a hernia and they end up being sent to me. So it's completely unnecessary for them to see a surgeon. A diastasis is just a midline separation of the rectus, where we normally have the linea alba in patients who have a six-pack that's just stretched out. So it's a weakness, it's not a defect. So there's nothing to repair or patch up in essence. There's no risk of incarceration because there's no defect. And obviously there's a high association between pregnancy and getting a diastasis. They think there's a hormonal component that might play a role in this. And I see a lot of times obese people, mainly female and male, but a lot of times male, with large ones. So these are different areas where you can get diastasis. This is the most commonly seen, or this one. This is the normal width of your linea alba. And then when they start getting bigger, that's when we call it a diastasis. So these patients don't need surgery almost ever. Only very severe ones are gonna need surgery. You wanna advise them to lose weight, to do core strengthening exercises. Insurance is never gonna pay for that surgery. I try, whenever I have patients with a true umbilical hernia and a diastasis, I tell them I'm gonna repair the hernia. This might improve a little bit, and if I have some laxity in the wall, I'll try to approximate it, but I'm not completely gonna resolve it. Usually this is the kind of thing that the plastic surgeons repair when they see when they do tummy tucks. So they imbricate from the outside. When we're operating laparoscopic or robotic, we're from the inside, so it's different. And here's an example with a true hernia and the diastasis here with the defect. So, I forgot to mention. So when they do need surgery, it's when their diastasis is so big that it's really affecting their quality of life. And that would be like, they can barely go to a bathroom, and now they have really bad constipation because they can no longer, push with their abdomen. They've lost the abdominal strength. So that would be one of the very few times they don't really hurt. It's just more like they don't like how it looks. Okay, so pre-op limitations. Every time we get a hernia, and every time we get a hernia reoccur after a surgery, it gets larger. Tissue is weaker and weaker each time, and it's harder to repair them. So we want to repair them right the first time. I tend to be a little bit more conservative with the post-op limitations, let's say, compared to other people. But I think I have a very low incidence of recurrence, and I tell them, let's make it right the first time so you don't have to go through this again. So you want to have them, I always try to have them stop smoking at least a month before the surgery if they smoke and if they think it's feasible. If they're obese and if they smoke, especially, I start them out sometimes on Wellbutrin. If they don't have any contraindication, and some patients are able to lose some weight. So usually I see them on hernias that are not concerning right now and they have discomfort, but you still can manage it or you can still reduce it. I send them home between 1 and 3 months and see if they can lose some weight and then operate them. So you want to have diabetes control. Ideally, if they're not on steroids, even better. If they're immunosuppressed, because their chances of recurrence are going to be higher also, weight loss. Pre-op, some people say that they've been told not to do anything or work out because it bulges out. There's no evidence that doing workout or physical activity before surgery is going to lead to incarceration or any other complications. So I just tell them to do activity as usual. If they're doing anything that really causes discomfort, then you can just avoid it. But just use common sense, or if you're doing something that bulges out, just push it back in after you're done. So hernia surgical risk. So whenever we repair a hernia, it doesn't matter which kind, we can always, one of the biggest concerns is recurrence. We still have like a 14% recurrence rate in general for hernia repairs. There's always the concern for bowel injury or a missed injury that you didn't realize you did at that time. Infection of the mesh, which could lead to a fistula formation, which can be very bothersome and complicated to treat. Erosion of the mesh into some tissue. Chronic pain, usually it may happen from an inflammatory reaction with the mesh that are on the over nerves, but normally it's because you've injured nerves. If you get chronic pain or you've tagged the mesh or sutured the mesh close to some of these nerves that go around, especially it can happen in open hernia repairs too, but I think it's a little bit more possible in minimal invasive repairs because you have a lot more nerves that you have to avoid in that area, in your triangle of pain. And they, especially in men, they can have urinary retention. So I always have in my surgeries, I always have patients urinate before we go into the OR to avoid having to put a Foley, which in some men, if they have BPH, it's going to increase the possibility of getting retention after surgery. Obviously, if we damage the testicular, the spermatic cord, we can have testicular injury. Or you can damage the vas deferens, which is also very rare. Any surgery can lead to death, infection, bleeding. So experience for that surgeon makes a big difference in outcome. And they've seen that surgeons that have a high volume of hernias a year, at least 25. And if it's a hernia center, at least 40 a year for it to be high volume, are gonna have much better, less complications or better results. Having had a mesh in the past doesn't change anything about what you have now, or if it is a recurrence or not. It doesn't change. It can just get incarcerated just as well. It doesn't matter. And speaking of when we do a recurrence, if I've had also consults concerning that the surgeon went in, they're unable to find the mesh from an old surgery or unable to take it out because they can stick like chewing gum in a hair, in your hair. So if it's not bothering anything, or if you don't find it, who knows if they really placed one, who knows if it was an observable one, unless you have the OR report. So you don't have to remove it. If it's in my way and I can remove it to do a proper repair, I remove it. But otherwise, having a mesh in there, nothing's going to happen if it wasn't bothering them. You just repair your defect now. So when to use a mesh, we want to distribute tension, and this avoids sometimes help us avoid a recurrence. For all the defects in general, over 1 centimeter in a clean field, like I mentioned, with no contamination, we want to put a mesh in. Inguinal hernias, 100% of the time, except if you have contamination. Umbilical hernias, like we mentioned, only they say 1 centimeter here. In general, for umbilical, 1.5 centimeters, sometimes 2 centimeters. If they're slim, you can avoid using a mesh, and you still educate them and tell them, we're not going to use a mesh, less complication, it's a easier surgery, better recovery, less painful, but a little bit higher recurrence. So if you do get a hernia in the future, then we'll take care of it. But it's so tiny at first, so you'll be fine. We can do open, like we mentioned, minimally invasive, laparoscopic, or robotic, depending on however the surgeon feels comfortable or what you have available. And it makes the repair a lot easier, especially robotic in obese patients or with very large defects. So incisional hernias, these are hernias that occur after any kind of incision in your abdomen from any surgery or any stab wound or whatever, damage they had to the fascia. So almost pretty much always we should put one. We should put a mesh for these hernias. If they're only under 1 centimeter, if they're so tiny, then you could consider not putting one, just repairing it primarily. But these are hernias that already have weaker tissue because they've already been scarred. So the recurrence rate in incisional hernias is a lot higher than for the other ones that are for first-timers. During your post-op period, so there's a lot of debate still on how much weight you should lift or not and how recovery should be. There's really no data on post-op recommendations after abdominal and hernia surgery. There's significant concern still that if you do exercise or work out or lift weight early or too much at first, right after the surgery, fascia might pop back open and you might not allow what you repaired to heal properly and you might get the hernia again. So current guidelines right now tell us that to tell the patient to increase their activity level gradually as pain gets better. The same day of surgery, most of my hernias, unless there's a bowel injury or they were like from ER, they were obstructed pre-op, all the elective ones, they go home the same day. And you want to advise, you want them to walk, they can go up and down stairs, they can do almost everything except lifting weight at first. That's going to make your pain get a lot better. Then the debate comes of how long can you not lift weight. So there's more evidence that really makes a difference. So far, they've said the first 2 weeks. And they say that after 2 weeks, sometimes you can gradually, some people say, or some studies say, you can gradually start increasing your level of exercise after the first 2 weeks post-op, and then slowly start doing more and lifting more weight and going back to normal. And maybe before this, you can walk. After this, maybe you can start jogging. Like I mentioned, I'm more conservative on this side because people, as it is, they tend to not follow recommendations much sometimes. So I will always tell them to avoid anything that is equivalent to lifting weight. So anything that's going to increase your abdominal pressure, it might be getting up from a squat or getting up from bed or pushing something very heavy or lifting a baby, not necessarily like just working out. It's going to increase, it's going to be equivalent to lifting weight. So you want to avoid that for the first 6 weeks. So there's still debate between 2 and 6 weeks. It's okay. And I always tell them, some people say 20 pounds, some people say 10 pounds. There's some debate there too. Just anything that you feel the strength is going to be from your abdomen, just avoid it. Okay. After it is known, after those 6 weeks, I tell them 6 to 8 weeks, that's how long the incision itself takes to heal or to regain the most tensile strength it's going to regain. So I tell them after that time, there's no evidence that not lifting weight at all or anything in particular is going to make a difference. So if the patient really works out and is used to a very intense routine, you want to have them at 6 weeks, tell them to slowly start working their way up. There's no contraindication really. There's no evidence that going back to it is going to increase their chances of recurrence. But at first you're going to have discomfort. So you want to just slowly get back to it and start adding weight maybe or reps to whatever working out you're doing or routine. And then for inguinal hernias, the same, nothing has changed. I mean, it's been shown that early and progressive strain or the immediate return to physical work is not associated with the hernia recurrence. So the same, if they want to work on people who like can do light duties, for example, or work from home or on a computer, and they're not lifting weight, if they want to work 2 days after surgery, from my part, that's fine. And usually they want to at least take a week because hernia repairs, especially with a mesh, tend to be on the painful side. So they take a little bit longer to recover here. But normally over 2 weeks without working, if it's light duties, there's absolutely no need. It would be very strange. So, so when during the post-op period, we now know that we can close the effect, except in inguinal hernias in minimally invasive surgery, because you want to avoid hurting nerves. If we can close the fascia and then put the mesh, that's gonna increase our chances of, or lower our chances of recurrence significantly, and our chances of complications such as a seroma or infection. Okay, so or discomfort because it gets hard. And then fascial tissue, it heals quickly. So the first month is gonna be the biggest difference in healing, like I mentioned. We know the incisions itself takes over like a year to completely, remodel, but the first 6 to 8 weeks is gonna be the most significant part. So during the post-op period, we want to give these patients pain medication. It is extremely rare. For hernias is what I give the most medication for, and what I give them is just Tylenol coating, pretty much everyone. And I only give them like 16 or 18 tablets. So I don't really do days. I do, if you have pain, use it. If not, once you're done with these ones, the first few days, then you can go down to just plain Tylenol or ibuprofen. I try personally to avoid ibuprofen at first because some people might have bled a little bit more during the surgery, so you just want to avoid any bleeding, but you could use it too. So you don't want bed rest. That's a thing of the past. You want the patient to walk. Walking is going to help reabsorb the gases and the belly go down again and pain get better, even though at first it's not going to look like it. It's not going to feel like it. Plus, ambulation is always going to decrease your risk of getting a blood clot too. You're going to continue your diet as usual. There's no contraindication. I didn't do anything to your bowel, so you go back to normal. I close all my incisions on the inside with monocryl and then just put glue on the outside on the skin. So, but in general, everyone could shower the next day. There's no reason to have them covered. The only time I cover them is umbilical hernias the ones bulging out that I push back in. I might put a little like a cotton ball. So it pressures the belly button because I'm trying to have it heal, pulled in, which it wasn't before. And at first, I advise always to buy Miralax. I don't need them to go to the bathroom every day, but you just want them to not have to strain so much when they're going to the bathroom. Obviously, if it's a patient who had maybe like a chronic pulmonary condition, you want to try to control it as much as possible because you want to reduce all of that coughing after the surgery, because that's going to increase your chances of recurrence if they have a lot of coughing, and when they're waking up. And at first you want to control nausea as well. We give them always anti-nausea medication during the surgery, so they wake up and they're not, retching right after. So that's pretty much it. Any questions so far?
Thank you so much, Dr. Texidor. We do have a couple questions on the line. The first one that I got was, what is the role of urology consultation before inguinal hernia repair?
So there's none. Some urologists repair hernias. I don't know many, but some do. They don't have to get evaluated. Some men might have a component of a hydrocele and an inguinal hernia. If I know for sure they have an inguinal hernia, or that surgeon doesn't know how to manage the hydrocele, they might want to do a joint surgery. But a lot of times, once you repair the hernia, the hydrocele might go down. Or I tell them, I'm going to repair your hernia. If you still have the hydrocele afterwards, then you can go back. You can go to a neurologist. But there's absolutely no need to see a neurologist before a hernia repair.
Awesome, thank you. And then a second question that came on, given the population of
Okay.
how long would you give a bottom bunk after hernia surgery?
So question, are the bunks, do they have little ladders or do they have to like pull themselves up? If they have a way to go up without doing strength, then I would say maybe 1 week, 2 weeks, just because of the pain. They might have more pain in that kind of, you know, climbing up compared to like normal stairs. Normal stairs they can do right away, just do it slowly as you tolerate it. If they have to push them or pull themselves up into a bunk bed, then I would say 6 weeks, because you're going to be using your abdominal wall for sure. Okay.
Thank you.
Hiatal. Okay.
Yeah, they said that there was no ladders.
Okay. Yeah, so 6 weeks. And then someone's asking about hiatal hernias. So if a hiatal hernia is causing no symptoms, I would not do anything for now. Most gastroenterologists are going to tell you you have a tiny hiatal hernia when they do an EUD, unless that patient has significant reflux, or they have already changes in their esophagus of from the reflux and from the acid. Then a surgery can be done, or if you have a volvulus or a strangulation like I actually did last night, then you need to repair it emergently, but that's not the common thing. It's rare to get paraesophageal hernias that are emergencies. Usually some end up getting repaired because they had really bad GERD and they're sent to you, and usually those patients are going to be difficult to manage, but the ones that are going to respond a little bit better to surgery are those that respond to antacids somewhat. Okay. But if you just have one and they just told you and it happened to be there and you don't have any issues, just let it be. You don't have to pay any attention to it for now. Just let the patient know in case they ever have any issues. You know, they know they have it, but that's it, especially if they're tiny. And how can you tell when you reduce a hernia? Okay, so that's a good question. Whenever you reduce a hernia, you feel like a sound. It's kind of weird, but normally a lot of times it's bowel what you're pushing in. So you're pushing in bowel and you end up with an empty space in that hernia sac when you push it back in. So you're gonna you feel like bubbles sort of, and you're gonna feel like suddenly it's less tense as well. And if the hernia completely got reduced, especially if they're slim, maybe in obese people, it might be harder to tell. You're going to feel, if it completely went back in, you can feel the ring. Remember, the hernia is not what's popping out, it's the fascial ring. So if you can feel the ring completely, the edges, and you feel the hole in the center, and you can touch it with your hand, there's nothing coming out, it's reduced. That patient can go home, or if it's in an ER or whatever, they don't have to go to the hospital in that case. Okay. And ascites. So ascites is always an issue. If they have an umbilical hernia, you want to try to repair it when the ascites is very early, because a lot of people with ascites, as it progresses, they get worse and worse. And sometimes they can end up getting erosion of the skin, so they start leaking fluid out. And that's very troublesome, because then that's kind of more emergent, and at that point, the patient is not optimized, and it's much harder for them to heal, or for that wound to heal. So if they have ascites, that time you want to repair them as soon as possible, or when they're on the smaller side, and optimize your patient and control the ascites or improve it as much as possible right before surgery. Okay. And ideally, if they can be off steroids, if that's an issue, take them off as well. So fat-containing hernias, I say they're not emergent, but I recently had a case, for example, where the ER physician called me. He just tells me, oh, the CT scan says it's fat, which sometimes you can tell just on physical exam. I'm like, okay, if it's fat, they might get pain, but it's okay. It's not an emergency. If a little piece of fat dies, nothing happens. You can go home. So the patient comes to my office the next day. His fat was so strangulated, the little piece of momentum he had there in a very tiny hernia in the umbilicus, that all his skin already had cellulitis, and he had exquisite pain. That patient you want to do right away. But if it's only fatty tissue, you're normally going to feel it more like lumpy. and it's not really causing any issues, it's not, you know, you don't have any skin changes, they can wait. Parostomal hernias, so that's a big issue sometimes. The same, just tell them to push it back in. Those, as they get bigger, they're gonna be much harder to repair, and they end up needing sometimes surgery with the, if you cannot repair it right there, a lot of times you have to take down your colostomy, put it on the other side or somewhere else, and then repair that area completely. So those, I would say, send them for surgery as soon as possible. If it's a patient, when they're on the smaller side of the defect, if it's a patient who's gonna have a reversal because maybe it's a young patient had a perforated diverticulitis or a stab wound or whatever, and something that you know they're gonna be able to get reversed. Normally within, I go for 3 weeks, but 6 to 8 weeks for the most part, you can already take that colostomy down. So you're gonna just advise them, just like pop it back in, push it back in, until we get to the surgery date. And then, you know, they're gonna connect you and then repair the hernia, at least primarily. And that's one of the times where that's gonna be another issue, putting a mesh there, you have contamination, so they have to decide if they're gonna use a mesh during that time when they're doing the connection or not.